I would like to introduce now the team of the Medica Pathology Institute here in Zurich, Ines Raineri, Sandra Kilgus, and Fridolin Banwart. We have prepared now several cases for you. We like to discuss with you some imaging cases. Maybe I can see the first case. This is a patient, a 70-year-old male. He's a smoker, and during an endoscopy, an incidental finding of a 12-centimeter large circumferential lesion in the esophagus was found. And I would like to show you first this regular endoscopy image, and I think this is the most important for us. What we have learned from Haru's presentation is already we have to look very carefully. And the first point is when we look at the squamous cell epithelium, we have to look for reddish changes in the regular squamous cell epithelium, because this is the first indication for us that something is wrong. So in this picture, we also see here this slight elevations of the mucosa, and we have now a video using NDI. And here we notice these changes of the IPCL, and we first notice that this patient has almost in an area of 12 centimeters. He has no more regular squamous cell epithelium, and there are different kind of lesions in his esophagus. So we have on the one hand more polypoid lesions, and on the other hand we have lesions which seem to be more depressed. So in such a situation we usually perform Lugol staining. And also here, you notice that there are almost a circumferential area completely unstained. And after the Lugol staining, we use natrium thiosulfate, and you see here this typical metallic silver sign, also a sign for malignancy. We have performed an ESD in this patient. It was a borderline indication. The patient refused first the surgery, and we performed in this patient an ESD. But first, I would like to discuss now with Haru the changes we have found. And our purpose is first to try to describe the lesions, the different kind of lesions. Your opinion, is it mucosal, is it submucosal? And later we will see the operative specimen, and we discuss with the pathologist what they have found. So as I mentioned, this esophagus had two different kinds of lesion. I call it here lesion type A. So this lesion which is more protruded, and here we see very nicely the IPCL. So from my description, I would say these IPCL are more intense, but still I would suggest this is a mucosal lesion. What is your opinion?
Yes. Hello. Yes. So before evaluating the magnifying endoscope, so macroscopic observation of the lesion, the first impression is the most important. So in this case, you kindly show us the video clip, and then in the video clip, so we found lots of nodules. So basically, we suspect the submucosal cancer. Suspect submucosal cancer. Then, so after that, we perform the magnifying NBI magnification like this, and then evaluate step by step. This type A lesion, so we can recognize very well the IPCL. It's already irregularly arranged, but still keeps a loop of its original shape. So this is a mucosal lesion. And then protrusion. Protrusion is made by upward growth of the tumor, not a downward growth. So this is a mucosal.
Okay, let's go to the next area. This is a little bit more distal. So when I see this, I would also say it grows somehow into the lumen. And we also see IPCL. The diameter is not that enlarged, but it looks a little bit more than normal. So I would suggest maybe also still mucosal, or what do you think?
Yes, yes. So in this image, surface has the up and down. So we suspect a deeper lesion, and also when I check the vessels, it still keeps the loop shape but stretched. So that means the tumor, compared to previous image, tumor has more thickness, but still mucosal. So we don't find any extra large vessel or exposure of the neoplastic tissue.
Okay, thank you. Then I think this is here somehow the same. Looks also still somehow regular.
Yes, yes. This is not, still keep regularly arranged, but each IPCL has already changed. But this is also the findings of upward growth of the tumor, some papillary change of the mucosal surface.
And then the patient has somehow in between, we notice here that there are more depressed areas, like here.
Yeah.
And also in the next area here, it looks also we have less, not really a lot of vessels, and it looks a little bit depressed.
Yeah, in this kind of a very widespread lesion, so elevated area, so depressed area is a more risk of a deep invasion than elevated area. So this part is a more suspicious of a submucosal invasion. So we need a more close-up view, and then want to evaluate the is there any big vessel or not.
Closer view we don't have.
And then another point is the irregularity of the surface structure becomes worse than previous image. So this part may be the most deepest area.
So for you, a very important point would be that you say when the vessels are really huge and enlarged, then it's a definite submucosal invasion, but in this case, it's not so sure.
Not so sure, but the 11 o'clock direction, our surface, we can see some brownish dots, and behind we can see some green vessels. So
suspicious.
Yes, suspicious.
Okay, we have performed an ESD in this case, and now I would like to beg our pathologist to tell us what they have found in the operative specimen.
So we received this 8-centimeter-long formalin-fixed specimen, which was pulled up with 2 syringes. And basically, this is when you open it up, and you see this rugged surface, whitish. And here we have this depressed area you mentioned before. And basically, we cut it horizontally, and we completely submitted it for tissue processing. And basically, we had carcinoma in situ all over the place. However, in these locations, we found invasive carcinoma. And this part here, the depressed area, and also this part here, here was the deepest invasion into the submucosa, and here also was submucosal infiltration. You see here a cross-section of the specimen, and you already can assume here that you have a plus of tissue. And on the cytokeratin stain, you see very nicely carcinoma infiltrating into the submucosa and here being away from the vertical margin. Overall, it was a poorly to moderately differentiated carcinoma which grew in these tissue balls. You see here infiltration of the musculous mucosa. And what we also found, we've actually found really extensive lymphovascular invasion, which was confirmed here with a D240 stain. So in summary, we have a moderately to poorly differentiated invasive squamous cell carcinoma that infiltrated the submucosa and SM1. We had extensive lymphovascular invasion and resection was complete. The high-grade interepithelial neoplasia was very extensive and contained both proximal and distal borders. Together, we have a PT1B, L1, R0 with negative vertical and horizontal margins, and differentiation is a G2 to G3.
So there's no doubt that this is a surgical indication in this patient. For us is the question, first for sure we have to detect the lesion, but sometimes we have difficult decision makings with regard to the therapy. And my question is now, in this case, we have found two suspicious areas where we would suspect already a superficial submucosal invasion. And how is your strategy to decide whether this patient still can go for endoscopy or for surgery or other treatments? Yes.
This is a really tough case to make decision. So originally the tumor length is more than 10 centimeter. So another question is after circumferential resection, tubular resection of the esophagus. So another problem is a patient may become a severe stricture even after endoscopic resection, but patient refused surgery, so this patient is as a total biopsy we can do it. So, but of course the endoscopic image, some depressed area, vascular arrangement becomes very irregular. So that's a suspect like this histology, moderate to poorly differentiated, and also SM invasion. Actually, this patient has the lymphatic vessel invasion. So definitely more than 40% risk of a lymph node metastasis now and the future. So surgery is another option. But beforehand, it's very difficult to decide.
Another question is, we have sometimes borderline cases where sometimes we can accept a superficial submucosal invasion if we have an R0 resection, but the match deciding point is the lymphovascular invasion. Endoscopically, are there any features which suspect lymphovascular invasion?
Unfortunately, maybe no. It's impossible. But in the first image, second image, we can see some differentiated area. So it looks like upward growth. But in a depressed area, the vascular structure becomes very unclear and almost amorphism on the surface. So it strongly suggests the moderate or poorly differentiated squamous cell carcinoma, and then so such kind of lesion, so automatically increasing the risk of a lymphatic invasion.
Okay, are there any questions to this case? Okay. Then we have sorry. So the patient is a very special patient. He refused surgery, and so we treated this patient with to prevent a stricture with oral prednisolone, and we have followed up this patient now for exactly 7 months. Interestingly, this patient did not develop a stricture. I think we also have a video, because maybe you don't believe this. But finally, this patient did not develop a stricture. We have told the patient several times that there is a clear indication for surgery. And now, when the complete area is healed after the ESD, we will discuss if radiochemotherapy would be an additional option for this patient. This is the follow-up of the patient.